All right, so inflammatory bowel diseases. Crohn's disease and ulcerative colitis are our two chronic relapsing inflammatory conditions of the GI tract, collectively known as IBD, inflammatory bowel diseases. Crohn's, chronic inflammation of the intestines, more commonly affecting the terminal ileum, but it can infect any part of the gastrointestinal tract from mouth to anus. It is considered an autoimmune disease, and it's characterized by abdominal pain, diarrhea, weight loss being the hallmark symptoms, and malabsorption and steatorrhea, or fat in stool, are very common in these patients, which can lead to multiple nutritional deficiencies or even growth failure in kids. Ulcerative colitis is also a chronic autoimmune disease causing inflammation of the colon and rectum only. Does cause abdominal pain, diarrhea, and unlike Crohn's, usually rectal bleeding. It can also affect the body systemically. It can affect the musculoskeletal system, skin, eyes, or even the liver and gallbladder. There's an increased risk of developing colon cancer with ulcerative colitis, and malnutrition, just like in Crohn's, can result from chronic diarrhea or chronic inflammation, and even the medications used to treat the disease. So the etiology exactly is unknown at this point in time, but research suggests that individuals' genetic susceptibility, the environment, microbiome, and immune responses are all involved and integrated in the pathogenesis of IBD. One thing I want to talk about here is glycosaminoglycans, otherwise known as GAGs. Glycosaminoglycans make up part of the protective mucus layer, and they're essential to a functional intestinal barrier to help keep bad things out and provide an environment for these healthy bacteria to be able to grow. Inflammation, particularly driven by pro-inflammatory cytokines, has been shown to disrupt the production of these GAGs. Okay, so in patients with IBD, the release of tumor necrosis factor alpha increases these metalloproteases, which results in breakdown of the GAGs, including those attached to mucin, which are the ones that are these two layers that we're talking about. And the mucin layer in patients with active IBD is much thinner compared to healthy controls and has fewer complex glycosaminoglycans attached to them. So it's very, very important that we have these things attached to the mucin layer for protection. And the magnitude of the complex GAGs degradation is associated with the severity of IBD. So the less GAGs, the more severe the condition is. And it's reversed upon IBD remission. So they actually grow back, which is a good thing. As a result of the thinner mucin layer, of bacteria can easily penetrate the normally impenetrable inner mucin layer and trigger inflammation, vascular leakage, and the microthrombosis in patients with IBD. And that's where we start to have these ulcerations that are happening inside the colon and elsewhere found throughout the GI tract because we have lost the mucin layer, because we've lost these GAGs. And this is a great picture here showing this GAG layer here found along the mucin layer here. And we have a variety of GAGs. We're going to be covering more of these in part 2 of the lecture, where we're looking at things like hyaluronic acid and heparan sulfate and chondroitin sulfate. These are 3 of our GAGs that have been shown to be very helpful in repairing many different parts of the gastrointestinal tract, including the colon. So intestinal permeability in IBD, an impaired colonic mucosal barrier can lead to increased intestinal permeability. It's been demonstrated in patients with UC, and local leaks due to death of the colonic epithelium comprise the primary lesions in mild UC. And moderate to severe UC is characterized not only by extensive local leaks, but also by highly permeable ulcerous lesions. So the gut lining itself becomes permeable, and the ulcerous lesions make it even more permeable. So it's kind of a double whammy. Considerable evidence supports the presence of increased intestinal permeability in Crohn's. However, whether it's a contributing factor or a consequence of inflammation is not entirely clear at this point in time, but there probably is intestinal permeability going on in Crohn's as well. And then I've mentioned intestinal permeability about 1,000 times today. So what causes intestinal permeability? Food in and of itself, inflammatory food proteins, gluten and dairy, right? Corn. These things are known disruptors of the intestinal barrier. NSAIDs, nonsteroidal anti-inflammatory medications, which a lot of people who have these problems are taking to begin with, and it can exacerbate their problems. And other medications like antibiotics and trauma, stress, and radiation can also cause intestinal barrier disruption. So this is a great picture here. Again, here's our healthy person over here. We have our mucin layer. The mucin layer is great because, of course, helping with the barrier function and keeping bad bacteria out and contributing to the good bugs over here. We have short chain fatty acids. We're going to be talking about those next. They actually help with barrier function and increase Treg cells, which of course keeps autoimmunity at bay, and decreases the effector cells, which of course are going to be the ones that are eventually going to become aberrant and do the wrong thing. Over here on the right is more important. So we have dysbiosis over here, where we have bad bugs going on, where we have less commensal microbiome. We have less antimicrobial peptides. The mucin layer is degraded here in dysbiosis. Now we have bacterial penetration because we have a dysfunctional barrier. So they travel on through the intestinal lining here. And now we have decreased barrier function and decrease in Treg cells. And eventually that can lead to this whole cascade of chronic inflammation and pro-inflammatory cytokines being released and potentially autoimmunity, especially in the gut.